Hello and welcome. We are delighted to have today Dr. Peter Lachman. He is a consultant paediatrician who used to work at the Royal Free Hospital. He has a great experience in quality improvement and in patient safety. He has been the patient safety lead at Great Street Hospital, the national clinical lead for SAFE, which is an RCPCH program that aims to improve situational awareness. And he's the co-founder chairperson of the Pediatric International Patient Safety and Quality Community, which is also known as the PIPS Group, which is an international collaborative of several countries that aim to improve education and patient safety. So we're very lucky to have him with us today. It's an honour and a pleasure. Thank you, Dr. Peter Lachman, for taking us through Safety 1 and Safety 2.
Thanks a lot, Merit, and hello to all of you. I'm sitting in Dublin at the moment, and I hope that we have a good session. What I'm going to do is take you through patient safety theories over the next 40 minutes or so. And if you have questions, just put them in the chat box. I'm sure Merit will get me to look at those as we go along. So I'm really going to talk about quality and safety because they come together, and I'm going to put them as part of what's going on right now in the world of COVID. Lots of things have changed in terms of quality and safety. So there are 6 domains of quality, and what has really become more apparent right now is that safety involves both the protection of staff and the protection of patients. And that has been the experience worldwide about how we protect people who are giving care as well as protecting patients, because usually in the quality improvement field, patient safety refer to the safety of patients. And really, we're now talking about people safety, the protection of staff and patients. And the main thing was in PPE, which was the major factor in patient safety. Just because we're talking to a pediatric audience, the major safety problem in children is medication safety, and medication harm accounts for at least 40% of harm to children. So, and that's one thing that we as doctors can really sort out, because we are the main cause of that harm in that we prescribe either we overdose, underdose, or misdose. So, so these are all the kind of issues we can do. The second one, which is become very important, and even more so now, is the people-centered care. And again, I don't say patient-centered care, which is the normal thing. It's say people, because we're talking about, again, both staff and also about the patients, or the children in our case, and how we treat them with dignity, compassion. And right now in the COVID period, the problem here was how do we do that with highly infectious patients, adults, and how were they treated in terms of visitation, or when they were very ill and dying, how were they treated with that, and what were the ethics involved, and so on. So people-centered care has become more important. Timely care is one of the areas that has been problematic now. So and this is where, as I can say, just for the public testing, but really for the children we've seen, is what's going to happen with the collateral damage that we've had post-COVID for children who didn't have COVID, or children who just couldn't come to hospital because, and I do know that, for example, well, no, not at the Royal Free. I do know that their ward was closed, so the children who normally would have gone there had to go somewhere else, and some children didn't come in. There were a number of articles recently that showed that there was a decrease in the number of children who attended A&E, who attended hospital over the last 6 years. A decrease in child protection assessments, chronic disease was a big problem. So all of these areas could have been a problem. Efficiency of care is really important in that we have scarce resources, and how we develop them. I think that that's one of the areas people get most worried about when they come to patient safety. And then there's effectiveness of care, which is ensuring we give the right care at time. And I'll come back to that later. We normally think about that as being reliability. It's how does care become reliable, that we give the right care at the same time every time, and we make sure we follow guidelines, which is a big chain problem. And the final area is the one that I'm particularly interested in, is the equity of care and ensuring that people are treated equally no matter what they are. So I've been reviewing the social determinants of COVID and whether or not people are affected. And as you know, that children in poorer areas will have worse outcomes than children in more affluent areas, and that this is applied to adults as well as to children. So these are the social determinants of health, and how do we make sure we address them? So these are the whole quality periods, and I'm going to concentrate on patient safety right now for the rest of the talk. But even in patient safety, what you want to do is really look at basic principles of quality, which is you've got to plan for quality and you've got to plan for safety. It doesn't just happen. You have to have some kind of controls and measurements in place so that you know how you're performing. And then you have to have a quality improvement program to improve the quality of your safety. So that's called the Duran trilogy of quality management. And Duran was one of the theorists in the last century who came up with this, and it still holds in how we manage and our quality and safety programs. We can then look at how we understand improvement, and this is very important when you're trying to improve quality, is that you would first look at how the system operates, and for you, the system would be your ward. How does that operate, or your clinical area? What do you have to do in order to get the work done? So how do you run your ward? How do you run your clinic is the process in order to do it. And really to improve quality and safety, you have to understand your system. Then within the system, you have to understand the processes and the variation in the system. So for example, do all children get the same treatment no matter who the doctor is in terms of their condition, or is there variation in the process? And variation is really what we try to decrease in quality improvement. You have to understand the people who create the processes. Those are us, the doctors, nurses, allied professionals. So for example, what's quite interesting right now is that hand hygiene has always been a problem in particularly with doctors, and to try to get good hand hygiene. COVID kind of sorted that out. Suddenly everyone became obsessed with hand hygiene because they knew about the infection. But it's all about belief systems. So you could really think about hand hygiene in an outpatient clinic is very different from hand hygiene in an intensive care. And it's all about belief systems and how people feel the threat of being infected. So it goes with all the improvement processes. And of course, the way we make change happen and improve is the improvement methodology, which is not the subject of this talk. Now, these are the lenses of improvement, we call them, but when you're looking at safety 1 and safety 2 later on, you'll see safety 1 and 2 is all about understanding the system and learning from the system what works and what doesn't work. So let's get on to patient safety. Life in healthcare is very called a complex adaptive system. So you'll always have system issues. So when you study your system, you have these adaptive systems. So for example, if you have a child who comes in through A&E and has to be admitted into ICU, there's so many different systems that have to happen in order to get the patient into the intensive care. The number of systems in the hospital that have to adapt straight away. When I've been working in adult care, for example, if an adult comes with a stroke in the emergency room, there are 9 different systems that have to work together to see that they get the treatment within the 30 minutes they have to do it. So this applies for all. And it's also affected by the clinical complexity. So now our patients are a little more complex than they used to be. Children live longer with complex conditions. We are able to manage well. So our success had actually created a problem here, system issues. We then look at the culture, and I'd say that the culture is the most important part of both Safety 1, Safety 2, and it's really, if you want a safe culture, you have to have a system culture that facilitates the individual belief systems. And culture is really about your belief systems and how you can believe whether you're going to be safe or not and how to do that. Then we have what we call the individual processes, and these are really factored into the human factors. I'll come back to this very closely. The human factors affects all of these areas, and that is going to be part of the Safety 1, Safety 2. And finally, what we learned right now in the COVID is this ideas of resource and supply chains, the security and personnel for the staff, and access issues. So the new areas that come in. Now, all these factors have to come into play, and therefore, if we're going to have a safe system, we've got to ask ourselves how we're going to do that. So I really believe that this is one of the answers, is to really look at this from a human factors approach, and I recommend that you all read this paper. It's from Holden and Carrion. Carrion's an engineer, they're both engineers, and they come from Wisconsin, and they came up with the social engineering model, basically looking from an engineering point of view, how do we work? They look at the work system, they look at the processes, and they look at the outcomes that you want, desirable and undesirable. So in the work system, and you can say in our clinical system, we have people, which are the patients, the children, and the providers of healthcare, that's us, doctors, nurses, allied professionals, etc. We all have to do tasks in order to get our work done, and sometimes we don't know how to do the tasks, or their tasks are too difficult. We need tools and technology to do our work. We need an environment in which we can work safely, and we also need to have a team culture and organization that allows us to work. And this is called the microsystem, and this microsystem is what we have to look at every day in order to see if we can get it to work. And just think about this, I'll come back to this later again, because in both Safety 1 and Safety 2, that's what we're talking about. How does the work system get its work done? And that's we have this idea of processes that are going to work, and we're going to get outcomes. Good ones for ourselves, good ones for the patients, or sometimes not so good. And there's always these feedback loops. So this is what they call the SEEPS model. This is SEEPS version 2. There's 3 versions. And I really recommend this for all of you, as that's the foundation of safety, whether it's Safety 1 or Safety 2. So what we're going to look at is certainly after that, we have to look how do we get to reliable care. And this is now part kind of between the two, Safety 1, Safety 2. So it's preoccupation with failure. And we also say, if we look at the Safety 2 side, we say preoccupation with success, because we want to learn from success. So you've got to look at both the failures and success. And that's the smallest thing. So for example, by prescribing errors, I'd look at the accuracy of the scripts. They have to be 100% correct. That's what we're talking about, preoccupation with failure. Sorry, and get back. Remember that everything's very it's very complex. Building resilience, this is where I'm going to talk about. This is very much in Safety 2 area, building resilience. Sensitive to operations means that everyone in the team counts, and you'll see how important that is. And deference to expertise. It's generally the front staff have most of the solutions to everything. Now, this comes from a group called, from 2 authors, Week and Sutcliffe, and they wrote a book about managing the unexpected. And that means that you're always expecting something to happen, and that you can manage any situation. And they call this high reliability. So this is one of the areas of patient safety, and I think that we really need to incorporate this. And I'll show you how this can be done and how we did it on the SAFE model in order to do that. You have to understand the key issues that we do face. We work in teams, and this has become even more important nowadays, and our clinical team has to have a flattened hierarchy. We need to have good communications within the team. We need to break down silos between different parts of our team and different parts of our work. So for example, I've never really understood why this happens, but we have a nursing handover and doctor handover that is side by side, and they don't really meet, and they're sharing information but not to each other. So we need to look at how we can break down those silos, and that means adapting traditions of the way we work and when we work and how we work. We need to look at our professional boundaries and whether or not these can be broken down. In the last 3 months, professional boundaries definitely have been broken down as people have worked across professionals. I was on a call last night and they were speaking about people who could were virtualists. They could do virtually anything. They weren't specialists anymore. So it's really thinking about different ways we can work together. And then finally, going into the safety 2 area we're going to spend a little time on is looking at psychological safety. How can we be safe at any time in order to work together? So the key issues really that we are facing is looking at the basic needs of both patients and of staff, learning this idea, concept of situation awareness, which is fundamental to safety 2 and 1. Looking how we're going to fund everything, looking at accountability, how we have that with our teams, who will deliver the services so that we can have the right tasks done by the right people, and finally looking at the sustainability of what we do. So these are big issues that we have to face as we develop safe systems. So basically, what we really want people to do is, and this is one of the take-home messages, is as we're moving into building safe services, how do we analyze the process, see what needs to be changed, do multiple tests of change, and think laterally. So that's just an introduction to the overview of what I'm doing now. This is from a paper that was recently by Charles Vincent and René Alberti, two of the thinkers in patient safety, in which they said that basically safety needs to be managed proactively. And in both safety 1 and safety 2, that's what we were trying to do. Actually, safety 1 was more looking retrospectively, and safety 2 probably prospectively. I just like to talk about safety rather than safety 1, safety 2. So think about this is what we'd have to do is we shouldn't be improvising our safety. We should be thinking proactively, thinking about will it be safe in the future? Are we safe now, and will it be safe in the future? And what we have to do to be safe. So firstly, we need to manage the current risk proactively, and this should be done on a daily basis, saying of anticipation of what can happen. We need to know that actually we work in a very risky business. Healthcare is full of risk, more than most places, and we have risks every day. And we have chosen to be pediatricians, and the highest risk people in safety, or people at most risk, are the very young and the very old. There's a lot of similarities between the very old and very young. So neonates are at the highest risk of all. And then as you get older, the risk decreases. You get new risks, but really the hazards and medication harm is highest in the smallest, and those are the people who we look at. We really should contextualize the risks in your own area. So your risks, the risk profile for a neonatal unit is very different from the risk profile for an outpatient clinic and for an inpatient ward and then for a specialist ward. So it's really understanding your own risk. And really, next one is understanding how to engage all levels in the hospital from the front line backwards to the problem. So here's from Alberti and Vincent, who have a book that you can download. This book is available free of charge, and so it's safer clinics, safer systems, and basically they say that you have a look where you're working. So if you're working in the ultra safe area, which is like aviation, they say that is more like radiotherapy and blood transfusion. And so you follow the guidelines, you follow exactly to the T what you're doing when you do blood transfusion and radiotherapy. There's no deviation. Then you have the high reliability areas, which is most of our work, surgery, chronic care, and so on. We know what we have to do. And then you have the ultra adaptive, which is what we shouldn't be doing most of the time, but a lot of us do that, is where you have to really adapt, and that's really trauma and innovative medicine. And as you can see below, they put what other kinds of activities are very like this. Very unsafe is that you have to 10 to the minus 2 is 1 in 10 problems, 1 in 100 problems. And there you have, as you're going on there to the nuclear industry, civil aviation is very, very safe. So what we're trying to do is understand your risk profile. So that's the first thing, is where I'm working, how risky is it? And if you're in a neonatal unit, that's very risky. If you're in and you really want to really try and reduce risk. If you're an outpatient clinic, seeing chronic care and diabetes clinics, you manage high reliability. You want to be as high reliability as you can. If you're in a hemophilia clinic, you want to be in ultra safe to make sure that, because you're using blood products. So it's really understanding your risk, and I think this is very important. People really haven't done that before. And then you have to understand the safety system. So these are the theories of patient safety that we use. And as you can see, we go from, the first starts with individual responsibility. We all have that responsibility to be safe. When things go wrong, incidents happen, we have to know how to manage them. And there's a whole methodology. Now that is what is usually called safety 1. Then we go on to the human factors, which I've already started to talk about, the SEEPS model, and how we actually design for safety. And that means we have to understand how our system works. We have to then apply within that system the reliability theory I've started looking at. So we're paying every attention to every detail and learning how the system works. We then develop what we call situation awareness. And as you can see now, we're moving into the safety 2 territory of resilience and safety 2. So as you can see, it's a continuum. There's not one or the other. And as we go on our safety journeys, we have to apply all of these at every time to make sure that we get into a safe system. So safety 1 starts with individual responsibility and ends with safety 2 and resilience. So this is theory, but how can we do it? So in the program I ran at the college called Situation Awareness for Everyone, we first tested it out at the Royal Free, how the system would work, and we applied each of these theories into the process and to make sure that this could work. So let's start. Individual responsibility is very important, but you cannot be responsible if you don't feel psychological safety. And come to that in a second, psychological safety, because it's a very new concept. And it's about being able to speak up and to say when things are not going well, and to be able to say, I can't do the task, able to get support. And we're not very good at that, really. So you have to feel safe, and that allows you to be safe and allows you to act safe. So you can't act safe if you don't feel safe yourself. And so let me just go on to some psychological safety.
I want to describe 4 important outcomes of psychologically safe work environments. The first one is learning. The second one is risk management. The third is innovation. And the fourth is job satisfaction, job meaning. So first, let's talk about learning a little bit. And by learning, I mean 2 things. I mean your own learning. If you're in a psychologically safe work environment, you're more able to listen, to ask for help, to gain better data on what's happening around you. But maybe just as important, or even more important, your organization is able to learn, your team, your unit. Let's say you work in an intensive care unit. Psychological safety allows you to speak up about what's happening, about what you see. It allows you to point to something that might be a process failure, that might be a discrepancy from what you think should be happening. So it allows people working together in intense, interdependent work environments to speak openly with each other, and often, very importantly, to ask for help, to ask for input. A second one is just plain risk management. Because people are able to discuss risks thoughtfully, skillfully, they are better able to manage them as a collective. In healthcare, like many work organizations, but often in an even more extreme form, the work is highly interdependent. That means that patients' outcomes, patients' health, very much depends on the skillful coordination, discussions, decision-making among different clinicians, different caregivers. And so psychological safety is an input that helps people discuss risks thoughtfully, make decisions skillfully, And that way they're better managing the very real risks that are always present in the healthcare setting. Innovation is another crucial outcome from psychological safety. When people have a sense of psychological safety at work, they're better able to brainstorm. They're better able to offer possibilities. They're also better able to assess and test ideas and see what works and engage in rapid cycle learning processes that allow us to work together to figure out what really works and what's going to be a great new opportunity for the future. A fourth outcome of psychologically safe work environments is job satisfaction. People who have a high sense of psychological safety at work feel more valued and feel more respected by their colleagues, by their bosses, by the environment. And so they feel better about the job. They feel better and more committed to keeping that job over time. This is obviously a really valuable outcome of psychological safety. When people have longer tenure in their jobs, it's better for the patients, it's better for the organizations, and it's better for the colleagues.
So that's Amy Edmondson on psychological safety, and I think this is really crucial. It's very, very topical right now. Let me just show you some more.
So let me tell you three things that need to be done that make an enormous difference in creating psychological safety in the workplace. The first one is framing the work. And by that, I mean two things: adding meaning to the work. Why is the work we do so profoundly important? People's lives depend upon it, for example. Now, you might think that's obvious and doesn't need to be said. I would argue it does need to be said, because when people in positions of leadership, as I said, all the way up and down the organization, remind us of what's at stake and why it's important, it brings us back to why we're here, why we're doing this. It brings us, in a sense, away from that need to manage others' impressions of us and back to the actual work that we do. But that's only the first part of framing the work. The second part is reminding people that the work we do is uncertain and is interdependent and has a lot of potential for error, potential for things to go wrong. If I remind you of the nature of the work we do, it makes it quite clear how important it is that we're open, that we bring our full selves to work. In other words, if I remind you the nature of the work, the riskiness of the work that we do, it just creates a kind of invitation for you to take it seriously and bring your full self to work. The second thing that leaders absolutely have to do is what I call model fallibility and invite input. So these are behaviors. These are really important leadership behaviors that help other people experience a sense of psychological safety. So by modeling fallibility, I mean very simple things. If you are the medical director, for example, of an intensive care unit, modeling fallibility might involve behaviors like saying, "Hey, I may miss something. I need your help." Now think about what a simple statement that is. It's a simple statement of fact. I may miss something. After all, I don't have eyes on the back of my head. I need your help. And so I'm modeling fallibility. I'm letting you know that I am a fallible human being, as we all are. Ergo, your input is crucial. So I'm modeling fallibility. The second thing I'm doing is I am actively inviting input. What does that mean? Very simple. It means I'm asking questions. I'm saying, and often it's helpful to say directly your name, the other person's name, and say, "What do you think? I'd love your input on this. What did you see? You're on the overnight shift. What did you notice? How are the patients doing?" If I ask you a direct question, I lower the very real psychological costs of you having to speak up, in a situation of hierarchy. So by modeling fallibility, very simple, very straightforward way, by inviting input through asking genuine questions, I do an enormous amount wherever I am in the organization in creating psychological safety for others. The third thing that leaders must do to create psychological safety is what I call embrace messengers. When people speak up, when people offer ideas or point to a process failure, thank them. When people are willing and able to come to you and to offer their ideas, their concerns, it is absolutely crucial to thank them, to acknowledge and make it a positive experience rather than a negative experience. You've got to close that loop. Otherwise, people will initially take the invitation seriously, that you are serious, that you want people to bring their full selves to work. But if there's never anything in it for them, that behavior will die out over time.
So basically, that's the crux of patient safety 2, I guess, of safety 2, is really building psychological safety so that when you do have incidents that you do get, people feel safe about reporting them, investigating them in real time, fixing the problem, learning, which is a crucial part of psychological safety, spreading the learning, essential. We often don't do that. And finally, back to being aware again, the cycle. So you can see that psychological safety is essential, and incident management, which we called risk management in the past, I guess they still do, is the safety 1 part, but it is part of safety. It can really work if you have the psychological safety to do it. I mentioned the human factors just to remind you again how important it is that we understand how our systems work. So I'm not going to spend time on the slide again. And then the aiming for reliability. And this is again what I pointed out earlier. Small areas or small successes, paying attention to the front line. That is where the psychological safety is really happening. Encouraging diversity, that's where the psychological safety is happening, as you heard in those videos. Learning and building resilience, that is safety 2. All of these, sensitivity, reluctance to simplify, are safety 2. And finally, deference to the expertise. So you can see this reliability theory embraces safety 2 and embraces the idea of psychological safety, because you can't do any of this unless you're feeling safe. Now, situation awareness is what we use to do in the SAFE program. It's enabling everyone to know what's going on. So as what we do is we gather information, we recognize, understand, and you lead to anticipation of what happens. So it's already anticipating what is going to happen so that you aren't surprised. And so this idea of perception, comprehension, projection of what's going to happen, making a decision to mitigate against any harm, having action, and then getting a worldview that everyone shares. And this is the constant going on, constantly the whole time. And actually, I like to use sports metaphors to show about situation awareness. This is what footballers would do when they're playing. They're anticipating where Messi will be. It's not a surprise when they kick the ball in that area, because they've already gathered information, they watch the way they're running, and they know exactly where the where he's going to be. This is what tennis players are doing the whole time when they're playing. This is what chess players, grandmasters are doing. They're trying to understand the future, and they can project. Now, this is a move from what we normally do in healthcare to respond to what's happened. So when a child has deterioration, we react to the deterioration rather than having anticipated who would deteriorate. So Eric Holnagel is the real theorist about patient safety 2. And what he really says is that healthcare is very variable, and we have to understand what's going on. We have to be resilient under all conditions, both expected and unexpected conditions. And that's what he's talking about when he talks about safety 2. It is more than learning from what goes well. It's about being able to respond. And that's where situation awareness comes in and where psychological safety comes in. So listen to this video.
My name is Sidney Decker. I'm a professor at Griffith University. And for the past 20 years, I have studied why things go wrong, why a patient dies of a medication overdose in a hospital, for example, or why an airliner crashes. So why do things go wrong? Well, we used to believe that things go wrong because somebody makes an error or something breaks. Today, however, we believe, and we have since the mid or late 1980s, that things go wrong because lots of things, little things, larger things inside the organization are wrong, have been wrong for a long time. These are things related to procedures, culture, design of equipment, supervision, work practices, and all these things can combine to create the potential for an accident. Now, this has been an extraordinarily empowering idea. It has shifted the focus upstream to the system surrounding the work that people do. We now expect organizations to have vast systems in place that are all supposed to look for these holes, these little wrongs, and fix them before they can combine to create trouble. The risk becomes that we invest in safety work that focuses on the higher frequency but lower consequence events, such as people not wearing their safety glasses, having their coffee in a cup without a lid on it, and that we then mistake low counts on those things as a statement of the general safety health of the process or operation as a whole. So we used to know that we were safe if we had competent managers and people at the sharp end who knew what they were doing. How do we know whether we're safe today? We have the paperwork to show that we are. And then we blow stuff up. How did we end up here? Here's how. We still see people as the problem. We believe that as long as we have great systems in place and that people conform and stay within the narrow bandwidth that we have assigned to them, things will be okay. But this is an illusion, and it is increasingly a dead end. People are not the problem we need to control. People are the solution that we should harness. I don't believe that things go wrong because things go wrong. That's a tautology. It's saying the same thing twice. I believe things sometimes go wrong because they usually go right. Think about it. What does a successful organization need to do to survive in a dynamic, resource-constrained world? These organizations make sure that they optimize locally. They hunt for local efficiencies. But the problem is the cost of those gains may be borne in other parts of the system through a series of interdependencies and interactions that they don't know about. Successful organizations will make small steps to make productivity gains, but by doing so, they borrow against their safety margins in ways that they don't measure. Now, these are normal things for successful organizations to do. So if you're successful as an organization, make sure that you have people on board who are capable of questioning and critiquing the way in which you achieve that success. Make sure you have a diversity of viewpoints. And if you want to stop failure, if you want to prevent failure, stop looking for it. Start looking for what makes your organization successful.
So what Decker is talking about is safety too, and psychological safety. And just to say, I want to just put something in right here, is that sometimes you have CQC come and visit, and they're the regulators. And really what they should be looking at is how can we make it safe in the way that Decker talks about. So in the last few minutes, I'm just going to show you how we do the situation awareness with clinical teams, which is all about safety too, psychological safety, and building it so that people can be safe and do this every day. So on situation awareness, where you really want to know what's going on in real time, this is a definition from Ensley, who was the first theorist on it, but knowing what's going on now so you can project to the future. We base this all on the human factors. As you can see, this is the third time you've seen this picture today, so you can see how important this is for being safe in safety 1, safety 2. And for you as clinicians, what we want to do is being aware of what's going around you in real time, not in past time, actually thinking what's going on, anticipating what the future is going to hold. And so something you can do really tomorrow is that before you act, you stop, and you think, you look at what the hazards are for you and the patient, the child in front of you. You assess your work system and the hazards using that SEEPS model, and then you manage it going on. So here you're constantly assessing. And what we really want to teach in safety 2, as it says, is assessing why things are going so well, so that when things do go wrong, we know exactly what's happened. And rather than concentrating just when things go wrong, and using this work system understanding the whole time. And there you see the gathering information. I've done this before, so I'm not going to do it. And what we did in order to do this, we introduced the huddle, which was a safe forum, which had to be psychologically safe. It's a brief meeting in order to see what's going to happen, have a shared understanding. And what we found when we introduced this, we improved both psychological safety of the clinical staff and the safety of the children, decreased referrals to intensive care, for example. And we were identifying, mitigating, escalating, identifying, mitigating, escalating the whole time. Meeting for 5 to 10 minutes maximum, virtually on tablets nowadays, telephonic, and key is understanding and what's going to happen. And I think that this is where safety 2 and safety 1 meet very nicely. And then I'll just talk about safety, because as you heard in the videos, everyone's opinions count, everyone's respected, the hierarchy changes, people feel safe to speak up, and you include all of those views of the patients and the families. And it's really a real framework for doing it. So this is what we'd like you to do. And this is safety 1 meets safety 2, asking every day, what do we do well? And saying, did we harm anyone in our clinical area? Are we reliable? Are we listening to the frontline staff to what's really happening using human factors? Are we anticipating what will happen? And most importantly, are we learning? Are we learning? We need to be in learning environments. So I'm going to just end now because these last few slides are just some of the things that we would look at in the next period of time, identifying those children who have these problems, so with their family concerns, high-risk medications, more than one clinical team, a child in the wrong bed, or a child just not getting better. And these are all part of being psychologically safe. And the one thing is just not right, the feeding of people's nurses. So this is the huddle suite that we have, identifying, mitigating, and escalating. And what we try to do is put safety 1 and safety 2 into frontline clinical action. And if anyone's interested in doing this, just please feel to contact me. On the college website, we have a whole training program. We're not running out in England, but I'm running courses here in Ireland at the moment. And if you want to contact me, I have 2 email addresses, as you can see, the college in Ireland and NISPA address, and also I'm on Twitter. So thanks very much, and over to questions. Merit, over to you.
Thank you so much, Dr. Lachman. So does anyone have any questions? Feel free either to post it in the chat box or to say them out loud. I had a question. You were mentioning before about 40% of pediatric patients tend to have some kind of pharmacological error, and I was just wondering what from your experience.
No. It is that 40% of all harm is medication harm, not 40% of children. So it's the other way around. So when you look at what harms that children have, around about 40% are due to medication harm, which is either prescribing or administration errors and causing harm. And then you go on to the next one will be infections. And so, but it depends where you work, of course, because if you work in intensive care, then you get different ones like pressure ulcers and extravasation of fluids, etc. So, so it's all dependent on where you work. And when we give you the statistics, they're based on what is reported as well. So there's a lot of reports that we don't have. Now, what we really try to do is say that in the system, if I just went back to what we were doing before, So if we just look, I'm just going to go backwards to a slide. If we just look at this slide on the past harm, what we ask people to do is identify the type of things that could go wrong in their clinical area. So if I was in native intensive care, I want to know any intensive care, ventilator-associated pneumonia, central line infections, in the native intensive care, extravasation of fluids, knuckle pressure injuries, etc. And that's what we're trying to prevent in that area. And what you're doing well would be really is how do we manage to prevent any of these things happening, learning from excellence. But medication harm is the biggest harm in pediatrics.
Mm-hmm. Yeah, thank you. And from your experiences, what sort of initiatives are being done to address that? Because it sounds like quite a large number.
Yeah. So I'll give you just two. One that was on the SAFE program was from Watford, from Ashley Reese. He developed it. It's something we call the Druggle. It's been very popular, though anyone who's here from who's worked either in Watford or at Leeds, that's what they used to do. And Leeds took it up very nicely too. Is that constantly having a feedback loop on your prescribing. So the pharmacists and the house staff, the trainees meeting up regularly on a weekly basis to look at their medication learning, whether anything wrong. Because the first thing you want to do is get 100% prescribing right. Now, just although I see there are 15 people on, besides 14 besides me, if each of you think about prescribing errors in your clinical area, and are you getting them 100% right? And that's just where the reliability theory comes in, is saying you're paying attention to the smallest thing. So the smallest error on your prescription is an indication that a big error can occur, which can cause harm later on. So the first thing you want to do is get your prescribing right. So an example we did at Great Ormond Street, I'll give you two examples. One was in intensive care. We had a zero tolerance for prescribing outside of a sterile cockpit. Again, making this into, as you can see on this slide, the work system to prescribe. We said what you need is you need a quiet area where you weren't interrupted. That's your environment. You need a culture that prescribing had to be 100% correct. So that was the team culture. The person was the doctor who was going to do the prescribing. The doctor had to know how to do the task of prescribing, so had to be trained in safe prescribing. And finally, you need the tools and technology, which is the BNF, your local formulary, your calculator, etc. And you need to have that within a sterile cockpit. And the sterile cockpit is that once you went into this bubble of where you're prescribing, you couldn't be interrupted, because one of the big errors of prescribing errors is interruptions. And prescribing on ward rounds is a very risky business, because you're talking about the things, you're not listening, not paying attention to it. So this human factors area works very well for prescribing. And what you're trying to do is get 100% reliability in your prescribing. If you get 100% reliability in prescribing, then the chances of medication harm are much smaller. After you've done that, the prescribing goes to dispensing, and now the pharmacists are actually pretty good on dispensing. So they will fix that. If you go to any hospital, at least 20, I do know this figure is between 20 and 30%, sometimes more, of the prescriptions need to be corrected by the pharmacist. So that's where we really concentrate first, and we look at the processes, and what we want to get is 100% prescribing correct. Then we do the same for administration. So that's the kind of things we do.
Yeah, great. That really illustrates the preoccupation with failure and trying to bring high reliability.
And what we do is also a preoccupation with success. So we look for those trainees, or those doctors who never ever make a mistake in the prescriptions, and we really celebrate them. That's the safety too, building psychological safety. So people really aspire to do that. And it's surprising. I say to most leaders is you have to lead from the front with prescriptions and with medication safety. And because it's the biggest thing, is that if the leaders in the clinical area are saying this is important, then everyone will pay attention to it. If they say it's not important and they accept prescribing errors as the norm, then you're going to get prescribing errors and you're going to get medication harm.
Yeah, very true. Yeah. Yeah, thank you. I think, yeah, that's very helpful for us as trainees going into leadership roles in the future, about how we lead in a positive way, and how we also invite people for the teams that we're working in, and to help to create that psychological safety, so that we can empower those that we work with. Yeah, thank you.
Yeah, I can just say quite clearly, in pediatrics, if you're looking at safety, there are about 5 things that happen really all the time to children. And the biggest one is medication harm. And so if we can solve that, we decrease straight away about 20–30%, sometimes 40%, depending where you work. If you're in an intensive care, you're really looking at ventilator-associated pneumonia and line infections. Again, when I was at Great Ormond Street, one of the things that we did really concentrated on was central line infections. We used to have up to 30 a month, and we went down to 1 or 2 a month over a few years. And we got the longer we went on, the more difficult it became. However, it was really, by doing this, really studying this work system and understanding how it worked in order to get rid of line infections. So you can really, as young doctors who are going into leadership roles, start working on the key areas where children are harmed, and make it run. And really, then what happens is, when you're doing this what do we do well, you'll find that what you do well is that you've got no line infections, no prescribing errors, no falls, no ventilator pneumonias, etc., and you're celebrating success rather than looking at harm, and this past harm's getting less and less and less.
Yeah, great, thank you, that's so inspirational. Yeah. Well, I don't think we have any questions from people in the chat box. So yeah, thank you very much for your time. Thank you really for this great insightful talk, and we're going to upload it onto YouTube a bit later on for people who weren't able to attend today, so that they can catch up with it later.
Okay, that's great. If anyone wants to contact me, then feel free to do so. It's just right at the end. It's all gone now, but basically you can just email me or contact me through Merit. Thanks very much.
Yeah, okay. Thank you so much, Dr.
Okay,
Lachman.
thanks a lot. See you again. Bye.